I will give a brief introduction of both of you.
Yes.
Samantaka is MD Gynec, and he did 1 year fellowship with us, I think 3 years back or 2 years back. When did you complete?
Back, sir. Passed out 2 years back, sir.
2 years back. Currently, he is practicing at somewhere at Mysore. Tell me the exact location of your place.
Sir, it's a place called KR Nagar, sir. It's around 40 kilometers from Mysore. It's a taluka place.
Amazingly brilliant gynec. I am very, very confident about him that he is. I am sure he must be doing very, very good, and I am very confident that he will do amazing in his life.
Thank you, sir.
Dr. Manoj is today's speaker. He is from Nepal. Again, very talented gynec. Day before yesterday, in fact, we have seen one case of erectile dysfunction, and we have given papaverine injection, and just then it was Samantaka only who told me about the few of the dose modifications. So I
Yes,
thought
sir.
it will be a good thing to recall everything. Thank you, Manoj, for agreeing to give this talk. Manoj, you can take over. Please start.
So should I start, sir?
Yeah, please
Yeah.
start.
Okay. Good evening. Yeah. Teachers and conveners of the today webinar, Dr. Deepak Goenka sir, Chairperson, Dr. Samantaka, and Dr. Asta Gupta, and everyone who are logged into these sessions of webinar. We are going to present the vasoactive drugs that are used intracavernosal for the erectile dysfunctions. So though I don't have too much experience, I have just seen a few cases, but I have searched a few articles and few papers, gone through a book and concise presentation. So let's begin. What is the erectile dysfunction? It is defined as the inability to attain and or maintain the penile erection sufficient for the satisfactory sexual performance. So it is classified into organic and psychogenic erectile dysfunction. Organic erectile dysfunction could be because of the endocrine cause, neurological cause, vascular cause, or because of any structural etiologies. So there are several modalities has been proposed till date for the treatments of erectile dysfunction. These include psychosexual therapy, oral phosphodiesterase inhibitors, intracavernosal injection of vasoactive drugs, which is the today's weeks of our presentation, external vacuum device, penile prosthesis. So in the today's presentation, we'll only focus on the intracavernosal injection of the vasoactive drugs and nothing other than that. So let's discuss how does the penile erection occurs. So the penile erection is the neurovascular event controlled by the play of nervous, vascular, and hormonal mechanism. So what happened that here we have the cut section of the penis, and here we can see this is there is two corpora cavernosas, and this corpora cavernosas contain numerous sinusoidals. So that are the lacunar space. Here we can see below the diagram, which is the magnified image of it. Here we can see that there is the cavernous artery. The center of the corpora cavernosa, and from this cavernosal arteries originated, and these whole helicine arteries is have the direct opening into this lacunar systems, and the blood get collected into this where the blood drain into the emissary vein, and from emissary vein it goes into the circumflex vein, and from the circumflex vein it goes to the dorsal vein of the penis. So this is the normal anatomical structure in the penis. So what happens physiologically when there is the no erections? So in the flaccid condition, there is sympathetic tone is dominant. So because of the sympathetic tone, penile smooth muscles is contracted, penile arteries are relatively constricted. So all the arteries, especially this cavernous artery, is constricted, and there is minimal blood flow to the into the corpora cavernosa, and the venous channels are open and blood drain freely. So this is the like the normal circulation in the flaccid state. Like the blood comes and then it is drained by the venous system. So it is the normal physiological state like in other part of the body. So what happened during the erection? So during the erection, first the parasympathetic activated. With the activation of parasympathetic nervous systems at the nerve ending in the corpora cavernosa, there is release of the nitric oxide. This nitric oxide, here we can see here in this below diagram, there is the nervous endings, and from these nervous endings, there is release of nitric oxide, and these nitric oxides activate Guwahati cycle. This cycle is increase the CGMP in the smooth muscles, and once there is increased CGMP and there is the decrease in the calcium, and with the decrease in the calcium the muscles get relaxed, and similarly nitrous oxide also cause the relaxation of the blood vessels. So what happened that there is overall relaxations of the blood vessels and the relaxations of the smooth muscle that is present in the corpora cavernosa. Because of this relaxation, what happened, the gas of the liquid, the gas of the blood comes into the cavernous artery blood vessels, and from that it goes into this helicine arteries, and from the helicine arteries it goes into the lacunae systems, and all the lacunae are filled with the blood. Because of this, there is increase in the pressure in the corpora cavernosa. Because of the increased pressure in the corpora cavernosa, the venules which are present inside the corpora cavernosa. Here you can see the small venules. So these small venules which are present into the corpora cavernosa get compressed, and the venous obstruction, and there is the venous occlusion. So what happened? There is venous occlusion and there is excessive flow. That means inflow is high but outflow is very much limited, because of which there is entrapment of the blood in the corpora cavernosa, and because of this entrapment only there is the erections. So that is the basic physiology. So what happened that after, so this is what I have already told. So I'll just skip this slide. So what happened afterwards? Once the erection is happening there, then there is subsides of the erection. So during the subsidings of the erection, what happened? There is the sympathetic discharge release the norepinephrine. Norepinephrine is released, and there is increased phosphodiesterase type 5, which break the CGMP, and CGMP is breakdown, and there is few CGMP only. If there is few CGMP, then the calcium will increase, and there will be smooth muscle contraction. Once there is smooth muscle contraction, the arterial inflow reduces, the venous channels open, and the penis returns to the flaccid state. So now let's talk about what are the vasoactive agents which we can use in the erectile dysfunctions. So these are the different vasoactive drugs that has been tried for the several years. These are papaverine injection, phentolamine injection, and prostaglandin E1. So I will just briefly tell the pharmacology of this drug. So papaverine, it is the non-specific phosphodiesterase inhibitor and direct smooth muscles relaxant. It is an opium alkaloids derivative, but it is not opioids, and so it does not have any analgesic or addictive effect. It has got action on the smooth muscle, that is, it inhibits phosphodiesterase enzyme. Phosphodiesterase 2, 3, and 4 are inhibited, which leads to the increase in the intracellular CAMP and CGMP that cause the reduction of the intracellular calcium, and smooth muscle get relaxed. So the papaverine injection will cause the relaxation of smooth muscle, and we have seen that with the relaxation of the smooth muscle, blood flow increases into the lacunar system. Now next talk, what is phentolamine? Phentolamine is non-selective alpha-adrenergic receptor antagonist. That is, it is alpha-1 and alpha-2 blocker. So normally alpha-adrenergic stimulation cause contraction of smooth muscles in penile arteries and tubercular system. Phentolamines block alpha-1 and alpha-2 adrenergic receptor. Thereby, it prevents the sympathetic mediated vasoconstriction. Next drug is alprostadil. So it is prostaglandin P1. It is naturally occurring prostaglandin glandin, and it binds to the prostaglandin inhibitors, prostaglandin receptor on the smooth muscle cell of the corpus cavernosum, and thereby again it increase the CAMP level. So as I have already told, if the CAMP level increase, then intracellular calcium level will decrease. Intracellular calcium level, if it decreases, then the smooth muscles will relax, and the blood flow will increases into the corpora cavernosal in the sinusoids of the corpora cavernosal. Now, talking about all these injections, so traditionally, first line treatment for erectile dysfunction was oral phosphodiesterase type 5 inhibitors, which is sildenafil. We commonly use even these days. And intracavernosal injection is therapy which is widely used as the second line treatments of the erectile dysfunction. Now, here the various combination of these drugs are used nowadays, and these combinations are very useful for the patient because there are different mechanisms take place when we combine these drugs, and this will alleviate the adverse effect of the drugs, and it also help them by reducing the dose of each drugs. So what are different combination therapy available? So this there are different combination therapy available. These are bi-mix. So in the bi-mix we have papaverine and phentolamines. In the tri-mix we have papaverine, phentolamine, and alprostadil. Also we have quadri-mix. Here one extra medicine is added, that is atropine in tri-mix. So so according to 2025 European Association of Urologist guidelines, papaverine 20 to 80 mg was first oral drugs used for intracavernous injection. It is most commonly used in combination therapy because of its high incidence of adverse effect as monotherapy. Papaverine is currently not licensed for the treatment of erectile dysfunction. Similarly, EUA says that phentolamine has been used in combination therapy to increase efficacy. As a monotherapy, it produces a poor erectile response. Phentolamine is currently not licensed for the treatment of erectile dysfunctions. Now, EUA says that both bimix and trimix has been widely used with the improved efficacy rate, although they have never been licensed for the erectile dysfunction. So, but when we combine these drugs, the efficacy is increased, and the combine is more preferred over the single use. So, talking about the bi-mix, in bi-mix we have the papaverine 7.5 mg up to 45 mg plus phentolamine 0.25 mg up to 1.5 mg, and in trimix we have papaverine 8 to 16 mg and phentolamine 0.2 to 0.4 mg and alprostadil 10 to 20 microgram. Now, trimix has higher efficacy rate reaching up to 92%, and there is lower incidence of the penile pain due to lower dose of alprostadil. So, when alprostadil is used alone, then it has got adverse effect to cause the pain. But when it is mixed with the other drugs like in the trimix, then the penile pain is reduced. So the fibrosis is more common, up to 5 to 10% when papaverine is used, and it depends upon the total dose used. So talking about the bi-mix, so in bi-mix we also have the papaverine plus chlorpromazine. So the chlorpromazine is an alpha blocker, has been used as a substitute to the phentolamines in the bi-mix with the similar efficacy. It is less costly and more affordable in the developed country, and so it is the one of the another alternatives. So in bi-mix with the papaverine and chlorpromazine, here the ingredients is in papaverine hydrochloride injection usually available as 30 mg per ml or 16 mg per ml ampoule, whereas chlorpromazine injection is commonly available as 25 mg per ml. So, so the minimal dose of the papaverine which we have to give is the 15 mg, or chlorpromazine minimal dose is 6.25 mg. So to take 15 mg, the minimal volume that we can take is 0.5 ml, because 1 ml contain 30 mg. Similarly, here 1 mg contain 25, 1 ml contain 25 mg. So to take 6.5 mg, we have to take 0.5 ml. So we take 0.5 ml of papaverine and 0.25 ml of chlorpromazine, or we can take 1 ml of papaverine and 0.5 ml of chlorpromazine. So the total volume will be 0.15 to 1.5 ml, and here we can use the insulin syringe for the proper dose calculation. And we can give this injection 5 minutes prior to planned intercourse. So as I have told, this is the minimal dose that we can give: papaverine 15 mg and chlorpromazine 6.25 mg. So we we cannot get adequate erection with this dose, then we can increase by 5 to 10 mg in the next visit till adequate erection we get, and maximum dose we can use up to 65 mg. Oh, sorry, 60 mg. So, and we have to limit the injection, a maximum 3 injections in 1 week, and the interval gap between one injection and other should be up to 24 hours. So we have to advise patient to visit if the erection lasts for more than 4 hours, where there is high risk for having priapism. But it is better to advise patient to stay in the clinic. We monitor the patients frequently to see if the erection subside or not, and once the erection subside, we can send patient to the home. Now, how to administer this drug? So to administer this drug, we have to take the proper aseptic precaution, and we have to withdraw the desired dose into the insulin syringe, and we have to inject the desired dose into the lateral aspect of the penis. So here we can see this is the cross section of the penis, and this is the 3 o'clock position, this is the 9 o'clock position. So we can inject at this 3 o'clock position, keeping into the perpendicular to the penis. So, and we have to avoid if there is any visible vein present underneath the skin, and alternate side should be used in each time. So if we have injected this side, then in next setting we have to inject in the another side, and we have to another side, and we have to keep on changing the site of the injection, so that it will there will be no fibrosis. And after giving injection, we have to give compression for about 2 to 3 minutes to prevent the hematoma. There are some auto injectors are also available. So the advantage of having auto injectors is that the patient can use these auto injectors in their home by themselves. So what are the efficacy here? We have discussed all the single drugs and combined drugs. So what are the efficacy? So according to the European Association of the Urogynecologists, they have said that the alprostadil has the 70% efficacy. Okay, and with the alprostadil, penile pain is the most common problem. So papaverine has when used alone, it has got less than 55% efficacy, and there is chance of having elevated liver enzymes, priapism, and fibrosis. Similarly, phentolamine has got very poor effect as a monotherapy, and it also has got systemic side effect. And actually, these drugs are not used as a monotherapy; they are abandoned, I can say. So the best is combination therapy. So the bimix has got the 90% efficacy, and 95% efficacy, even though it's not licensed for the treatment of erectile dysfunction. Trimix has got 92% efficacy, and it has got very good effect, and though this is also not a licensed drug for the treatment of erectile dysfunction. Now, going to the side effect. So, priapism. So, if there is the prolonged erection more than 4 hours, then it is called as the priapism. So, other side effect could be penile pain, fibrosis, hematoma, or systemic hypotension, which is the rare complication. So how priapism happen? As we have seen that there is increased CAMP and CGMP. So because of this, there is decreased calcium and there is prolonged smooth muscle relaxation in the corpora cavernosa. So it is often dose dependent, but can happen even at the therapeutic dose in the sensitive patient. The UA guidelines refer to the priapism subtype as two type, that is ischemic. So the ischemic is that there is good blood flow in the arterioles and in the lacunar system. And there is venous occlusions. Venous occlusion is there and there is good blood flow. So what happens that if we take the blood out, then the blood color will be more dark in this type of priapisms. And it partial pressure, if we measure partial pressure of oxygen, then it will be low. Similarly, here we what we will see that the blood flow, if we do the Doppler, then the blood flow into the arteries will be low. In the arterial, what happened? The blood flow is maintained. Blood flow is maintained. So maintained, and this is well maintained, and there is this type of priapism is non-ischemic, and it is not a too much emergency condition like the ischemic one. So the let's talk about the management of ischemic priapisms. It is the commonest type of priapism, and when it is refractive cases, it is the risk of smooth muscle necrosis in corpus cavernosus is there, which lead to the sequels of corporal fibrosis and erectile dysfunction. So there are certain increase the risk of priapisms, and these conditions are the condition where there is increased the blood viscosities, like sickle cell disease, thalassemia, and some hematological malignancy is if there. So what is the initial management of ischemic priapism? So the initial management involves the corporeal blood aspiration followed by instillation of alpha agonist into the corpora cavernosa. Here we can see this is the penis. So if inject the butterfly needles into the lateral aspect of the penis, and we spread the blood, and at the same time we can irrigate it with the 0.9% of the normal saline until the bright red blood volumes return. So this alone may reverse and reverse the case, and the priapism may subside. The intracavernosal agent recommended by EAQ for the injection are phenylephrine 200 microgram every 3 hours to 5 minutes to the maximum 1 mg within 1 hour. And similarly, other drugs that are recommended is etiliptine, adrenaline, methylene blue. So in non-ischemic type, where the blood flow is adequate, so these kinds of priapisms get resolved easily, spontaneously in few days. Because there is no ischemia and the penis is usually not painful, urgent intervention is not required. So treatment for this kind of priapism is cold compression, ice packing, penile compression, and mechanical compression with the penile tourniquet for the short duration, and we have to advise the sexual abstinence for few days. So medical therapy, usually medical therapy are not of too much helpful in the case of ischemic priapisms. So drugs that can be used are anti-androgens and GnRH analog. Mm, So intervention treatment can sometimes be required in this kind of non-ischemic priapism when it does not get relief and it causes distress to the patient. So this can be done, this intervention can be in the form of arterial embolizations, which is done by angiography. So embolization of the cavernous arterial branch or AV fistula using absorbable gel from autologous clot or permanent agents will be done. So thank you. Only my presentation. Thank you. Hello.
Astha, you have to unmute your, yeah.
Yes, sir. Thank you so much, Dr. Manoj, for such an elaborate presentation. It was really very nice. It was very good
Thank
to
you, ma'am.
revise all these things. So, are there any
you.
questions from the audiences? I want to ask Dr. Manoj one thing.
Yes.
Once a patient comes with erectile dysfunction, is there any criteria to decide whether we should give an intrapenile papaverine, or we can just give it to every patient with erectile dysfunction?
No, actually, intracavernosal injections will be always the second line drugs. So first line drugs will always have to be the other phosphodiesterase inhibitors like sildenafil.
Okay, so there is no particular criteria like we do a penile Doppler or something to decide whether we should give a papaverine injection or not.
No, I think there is not such a criteria. The first criteria will be the if the patient responds to the oral sildenafil or not. If patient responds to oral sildenafil, we have to treat with the oral sildenafil. If patient does not, then only we have to think about the intracavernosal injection. Since it
Sir,
has
do you
got the
agree
few adverse
on the
effects.
same thing? Do we need to look into vascular parameters before giving papaverine, or we can give it empirical to any patient?
As Manoj has told, Dr. Manoj has told, primary treatment is always the oral treatment. There was a time we used to do a penile Doppler, but lately most of the recommendation with what I have read is saying that no longer required. And if the patient is not responding with the oral treatment and there is no other organic cause, then we can try the this one, intravenous, intracarpus papaverine injection. There was a time we used to look into the size of the vessel and 0.6 millimeter or something like that, but no longer.
Okay.
Sir, I think even the patient has contraindication for sildenafil, like if the patient is on nitrates or isodril, then also the first line of treatment would be intrapenal injection, sir. If the patient has any contraindications for using drugs like sildenafil, the patient should go for intrapenal injection. That's what I read today.
Now, anyone has any opinion? Dr. Asta asked a very important question. Should we go ahead with the diagnostic first, then we have to go for the therapeutic? This is what Dr. Asta has asked, right?
Yes, sir, because I read few articles today which said about the blood flow in the penis in the Doppler, and if the certain parameters are deranged, they said ratio with the brachial artery, the pressure in the penis, and then if it is below 0.75, then only penile intravenous papaverine should be given.
If we give in such cases, what will happen? It may not work. It may not work.
Okay.
I'm just guessing. I have not read article. Just suppose we have given where it does not matches with the brachial artery. Then at the max, what will happen? It may not work.
Right, bilkul, sir. Sir, I have a urologist with me. Probably he will be a better person. Yes, sir. He's there.
Sir, sorry, I'm not prepared for this.
Arey, please.
Case, Dr. Asta was mentioning that brachial artery resistive index should be compared. So if it's less than 0.7, there is a venous leakage. That will be a PV, venous occlusive disease of penis. Then in that case, papaverine may or may not work. That will be requiring a higher dose for the increasing the arterial flow more than the venous leakage. So in these cases, a higher dose of this injection is required, bimix or trimix. Most of the time it fails because a patient has to take a larger volume and they are apprehensive about the volume of injection. So they think that it's not working and they are afraid of keeping it in the penis at the time of intercourse. So it leads to the penile implant in most of the cases.
So should we use this as a primary method, or once the papaverine injection fails, then only we can use it?
Sir, most of the time it's just psychological thing, as we all know. Tadalafil, sildenafil, or even a placebo can work. And in these years of my practice, I have seen that only out of 1,000 patients, only one is the real candidate who requires this papaverine, and out of 10,000, only one requires penile implant.
Right.
But as a competitive medical world, people are doing penile
Giving more
implant
frequently.
Yes, and they are putting patients on injections, and they are giving false doses to the patients so that that treatment, second line treatment, fails, and they'll end up in the surgery, which is costly, and it's a source of earning. So unofficially, this is a wrong practice.
Right.
But real candidates who do not give response to the tadalafil or sildenafil for the injection are just 1 in 1,000.
Right.
So are you doing penile Doppler before giving papaverine, or you're giving it without doing a penile?
Not required. Penile Doppler is most of the time is misleading and overused treatment diagnostic method.
Exactly.
And penile Doppler has no special role in treating the patients of erectile dysfunction. Any investigation which can help in making the diagnosis or in treatment is the right test. But in the cases of erectile dysfunction, tadalafil is the upfront medicine which gives the psychological boost to the patient. And after some time, they feel that they are not in the need of that medicine. They leave the medicine and they go on comfortably. Penile Doppler, in the cases of penile Doppler, which are usually done by the radiologist by giving sildenafil only. So that is not the right test. Right test is to inject papaverine and to see the systolic velocity and diastolic velocity and resistive index, these three parameters. But most of the radiologists are also afraid of priapism. So they do not do this test by the right method. They follow the new research papers where the sildenafil has been given without inadequate stimulation to the penis. Patient does not get stimulation. They report it as erectile dysfunction. No proper systolic velocity is there. So these reports are most of the time false. Observer and the object variations are quite high. So we do not
Yeah,
get
this is what I was talking about. Nowadays, penile Doppler is no longer recommended.
Yes.
Okay, sir. Thank you, sir. Anybody wants to ask any more questions?
We have a question from Preeti.
Dr. Manoj, please answer this question. How long we can advise self-administering injection?
So exactly duration. So we should not, as far as I know, we should not advise for the very long durations. So normally we can give 3 doses maximum in one week, and it depends upon the patient response. If patient get good response, and like in the psychological kind of erectile dysfunction, after few injection, patient start getting the erection themselves, or after that patient start getting the erection with sildenafil itself, then no need to prolong for longer periods. But if it has got no response, then we can increase the dose gradually to get the response. And once the response get, we can slowly decrease the dose. But exact duration for how long we can use, actually, I'm not clear about that.
Samantha, do you want to say something? How long a patient can use? 1 year, 2 year, 10 year?
Sir, Manoj was right there, sir. Whatever the articles I came across, they say about maximum of 3 administrations per week. I was going through a few US recommendations, sir. They also advise around 3 injections per week. That is what the maximum injections per week they have administered.
That you are talking about per week. How long? Suppose 10 years patient can have erectile dysfunction. Can he can continue using it for 10 years? Maybe 1 injection a week or once a month injection. Can he use for 10 years or 15 years?
I have not read about it, sir. I will read. I have not come across any recommendations like that.
Yeah, I have not gone through something like that, but I have patients who are taking this injection since last 15 years. They are still coming and taking from me. Sometimes
Yes,
they have taken a 2-3 injection in once in 6 months. They come to me and just take 2-3 injections. There are patients who are taking, as long as it is working and patient is desirous to have coitus functions, they can use it, I feel. And
sir, I was when I was going through, I came across a few interesting points, sir. There are many articles which say that alprastadil alone is as good as Bimix, and the chances of any apart from pain, there are no documented side effects with alprastadil. So even the newer formations of bimix and trimix, sir, they have reduced the dose of papaverine up to 15 mg, and they have added the other drugs like phentolamine and alprostadil to minimize the side effects. So that was one point I came across, sir. And Dr. Manoj, it was a very nice presentation, but I came across a slide where you told that the starting dose of chlorpromazine was 6.25. Am I right, sir?
Yeah.
I don't know, I might be wrong, but whatever the articles I have gone through, they have prepared a bimix or trimix solution with 2.5 mg of the medication, and they have started with 0.1 ml, and they have progressively increased the increment dose by 0.05 ml. I'm not sure whether that high dose is required. Whatever the recommendations I have come across, they have used papaverine of 30 mg and chlorpromazine of 2.5 mg. Because as you told, this is a new drug which is not recommended. Chlorpromazine, very few studies I've gone through. I think you've gone through Shamlal, one paper by Dr. Shamlal et al. He also recommends a dose of 2.5 mg. One vial has 2.5 mg, 1 ml or 2 ml has 2.5 mg, and that they have used, and 6.25 I have not come across, sir. I don't know. There might be other studies, but 2.5 I think
there are
the
significant variations in different studies, and getting this bimix and trimix is again a big challenge. Phentolamine is not easily available. Chlorpromazine is available only in I know is available only in one pharmacy at Delhi.
I remember you getting there, sir, from that.
I'm still getting from there only.
So is this self-injecting device is available in India?
I am planning to get. This is something new for me also. So I do have patients who definitely ask me about this. This is
So
something
because there
new.
are a
I
lot
will
of
get back to
patients.
this.
Yes, if it is available, then I think it's very good. We can prescribe to the patient to inject it, especially for females, because they are not injecting it intrapenile. So if the patient can inject itself, then we can also prescribe it.
Yes, definitely. It's
Yeah,
something new
but
for me also.
I think at IHR we used to prepare a solution and give it to them in the insulin syringe, sir.
Yes.
I think around the 0.3 ml of in insulin syringe, 375 microliters we used to prepare and give it to them.
I'm still doing the same.
Yes, sir. I think we used to give we used to inject one and give them two to take to the house.
Yes.
Right.
That's what I remember, sir, from IHR.
Regarding Rohit's question, are we allowed to use here in India? Yes, we can use, but as such, as far as my knowledge goes, Indian government doesn't say anything about the use or disuse. It is the FDA license which we are talking about, but in India, FDA licensing is not applicable. So we are using it everywhere. So as long as there are no complications, when we know how to manage the complications, this is all right to use.
Sir, the use of these injections are, as I was asking Dr. Manoj sir before, it can be used in patients where the oral medications are contraindicated, sir. If the patient is on nitrates, or if the patient is a patient who has undergone a recent cardiac surgery, in whom these oral medications are contraindicated, can these patients take intrapenal injections? Is the intrapenal injections the first
Manoj, any
line
comment?
of medication in these patients?
No, I have not gone through any such kind of articles, whether it can be used or not.
Patients on nitrite can be taken,
No.
but for the cardiac surgery, once the cardiologist gives permission, then only they can take. They're allowed, many times they are not allowed to have coitus only after the cardiac surgery. So if they're allowed to have coitus, then they can take these injections also. But with nitrate, these injections can be taken.
Okay. Sir, the quadrimix, are they using it, sir? As Manoj sir told about the atropine, is it being used internationally, sir?
I have no idea, because
Because
I have
sir, you
not
mentioned
seen
it, and I
using
also
anyone
came through. Yes, sir.
trimix also.
Okay. But I came across a few sites, sir, in the US where you can order it on prescription. As Madam was mentioning about self-administration, I could see many sites offering trimix and bimix on prescription in the US for self-administration. Quadrimix I did not come across.
Manoj, do one thing tomorrow,
Sir,
maybe tonight,
yes,
a self-injecting device. Just search in the
device,
Google
yes.
or Amazon. Is it available on the Amazon or somewhere?
No, sir.
Okay, sir. I will search.
Yes,
Dr.
I will
Manoj,
search.
Manoj,
Actually, that
you were saying
diagram I got
something?
from one article.
Dr. Rohit wants to ask one more question. He is saying how priapism leads to ischemia because there is increased blood flow in the penis. Please explain again.
So there is increased blood flow in the penis, but outflow is obstructed. So outflow is obstructed, inflow is there. So the blood flow will be accumulated just inside the penis, and all that blood will be the deoxygenated blood, and no oxygenated blood will be there. So that will be the ischemic type in the ischemic type. But in the non-ischemic type, the blood flow is the continuous. There is continuous blood flow going to the lacunar systems, lacunar system, and the drainage is also adequate, but not sufficient enough to drain the blood, whatever amount is going into the corpora cavernosa.
So Rohit, basically it is not increased blood flow, but there is a stagnation of the blood flow.
Any more questions from the audience?
Sir, what is if the patient doesn't have an erection with a bimixer, the starting dose is 0.1 ml. So how are we supposed to increment the dose, sir? Like how are we supposed to increase it?
Once a week, we can
whatever
100 microliter per attempt we can increase. Maximum dose is 1 gram, 1 ml. If
Yes.
within 1 ml also doesn't work, then they have to go for the implant.
Okay. Sir, also at IHR, what we used to do is we used to give a tablet give half an hour before giving in the injection, sir. We used to give sildenafil tablet. Does it have the synergic effect, sir?
Yeah, it has a synergic effect. Still, we are using the first sildenafil 50 mg, and then half an hour later we give the injection.
Dr. Manoj, Rohit is asking again, sir, are we allowed to treat priapism or should we refer the patient to urologist?
No, I don't think in all the cases we have to refer to the urologist. We can drain ourselves, we can irrigate ourselves. It is simple procedures. So draining and irrigations we can do ourselves. But if the complications happen somehow, if it is not getting relief, then sometime we need to refer the case.
But I guess because of medical legal issues nowadays, it is always better to take a urologist in a loop. That's what I think. So.
Yeah, that's fine. If we have urologist, it's better to take into the picture. But as my opinion and my view, it's fine. It does not lead to too much of complication if we just put a one butterfly catheter into corpora cavernosa in lateral aspect. It won't cause too much of effect, and we can do it easily. It is simple procedure.
बैठ जाओ, आपका बढ़िया तकिया लगा लो। आप बैठ जाओ, ऐसा नहीं तो इधर बैठो नहीं सही है, उधर तो सही है। तो बाहर चलो ना, अपन चलते हैं बाहर से, बाहर खा था। हाँ बाहर।
So should we end this meeting?
Yes, I think no. If no more questions, we can end.
Sir, I just wanted to ask not about the intracavernous injection, but about the like sildenafil and all. The article से मतलब सब लोग जो practice करते हैं या जो article से मतलब at our place we refrain from giving the sildenafil. मतलब हमारी जो senior consultant है, she refrains from giving it. लेकिन उसका ये है कि मतलब कितने लोग हैं जो पहले TMT या कार्डियक क्लियरेंस लेके फिर प्रेफर करेंगे कि सिल्डेनाफिल जो है वो यूज करें फॉर ED पेशेंट।
नहीं, कार्डियक क्लियरेंस क्यों चाहिए हमें सिल्डेनाफिल के लिए?
सर वो पहले भी मैंने कुछ एक आर्टिकल पढ़े थे, कुछ एक ऐसा वेबिनार भी सुना था जिसमें ऐसा था कि इट्स बेटर टू अवॉइड एंड गेट द क्लियरेंस डन और गेट द टीएमटी डन बिकॉज इट मे इंक्रीज द कार्डियक लोड एंड वैसा कुछ.
No, if the patient is hypertensive or if the patient is on nitrate, specifically on the nitrate, then only we have to worry about it. Then it is a contraindicated. But if patient is not on nitrates, then we can give it.
अच्छा, ठीक है सर, ठीक है सर. And apart from Deepak sir, anyone using themselves intracavernosal injection?
I don't know whether I have motivated anyone else. Astha is smiling that she is not using.
देखा तो
Sir,
sir.
I am a urologist, so I
know. You are in a privileged condition.
but sir, definitely because here in Delhi, all the even infertility doctor, they are not managing male infertility. They just send the patient to urologist. But I am the one who is managing each and every patient of male infertility. Although I have tried medical management also with HCG and gonadotropins, but yes, papaverine I am not doing.
Samantha, have you used in your
No, sir.
patients?
No, sir. So it's also, I don't know how everybody must be working in a big center, sir. You require a very good patient load to get patients who are not responding to the oral medications. Like most of them do respond to phosphodiesterase 5 in type A inhibitors.
I will tell you, sorry Samantha, I am interrupting you. I will tell you one thing. I think all of us are missing something somewhere. I am 101% sure all of us are seeing patients of unconsummated marriage.
Yes, sir.
I am 100% sure. I don't know how you people are managing unconsummated marriage. So there are two targets in this type of patients. Number one is to consume the marriage, to have successful intercourse. And second is to have pregnancy. Most of the time, we infertility practitioner, we don't look into the very important aspect of a social life, that is consummation of the marriage. We just treat them as an infertile couple. So if you want to treat them properly, adequately, then consummation of the marriage is equally important.
True, sir.
So, but that's also true that most of the time.
Astha, you are mute. Tell me again.
Yes, sir. So most of the time when patient comes to us, they have not consulted a doctor, but they have tried naturally for a decent amount of time, and they come to us with certain associated infertility factors, probably low AMH or something like that. So we are also at a pressure to manage infertility also. Because these consummation may require time. If the patient comes to us at a timely interval, that their AMH is good, they are young, the semen parameters are good, then probably we can give sufficient amount of time to manage this, because these things cannot be managed in a hurry situation.
Right.
But
Agree.
most of the time patient comes, they want a child, they comes to us infertility person because they are under pressure that they want to have child as soon as possible.
Right. So आज तक कितने साल हो गए प्रैक्टिस को? इनफर्टिलिटी प्रैक्टिस को कितने साल हो गए?
Sir, 2015 में I think I came to IHR, so almost 10 years. It's a
Almost 10
2025
years.
now.
So you are saying me 10 years में एक भी पेशेंट आपको ऐसा नहीं मिला, हाँ, जो कोई आइडियल कंडीशन में आपके पास आए? तो कहीं ना कहीं हम मिस कर रहे हैं इस चीज को. हम अपने थोड़ा सा इनिबिशन रहता है कई बार कि इंट्राकैवर्नल इंजेक्शन देंगे, कैसे देंगे. यू आर द बेस्ट पर्सन आस्था टू स्टार्ट दिस विद यूरोलॉजिस्ट बिहाइंड यू और नेक्स्ट टू यू.
Sir, definitely आपने motivate किया है. I'll definitely
just let us know whenever you give your first injection, papaverine injection, just let us know. Unconsummated marriage patients, they need a boost.
बिल्कुल sir.
I think if we don't have any more questions, we can finish the session.
Yes,
Thank
sir.
you everyone for joining.
Thank you.
And
Thank you,
Thank
Manoj.
you, everybody.
Thank you so much, sir.
Yeah,
Thank you.
thank you,
So
everybody.
much.
Thank you, sir.
Thank you, everybody.
Thank
Thank you, Dr.
you.
Manoj, Dr. Samantha.
Thank you, ma'am. Thank
Thank
you.
you.
Okay. Bye, everyone.
bye.
Bye.
Good night.
Bye.
Bye.
Good
Good
night, sir.
night.
Bye.